like to invite Dr. DEEKSHA KATOCH. Ma'am is an associate professor at the Advanced Eye Center and deals primarily with pediatric retinal disorders, especially ROP. Thank you, ma'am, for being here. And ma'am will be presenting a case of stage 4B ROP. If
Thank
you can
you,
have
Simar.
the slides quickly, one after the other, because we'll be short of time.
Thank you, Simar, for the kind introduction, and thank you, Dr. Tapas, for a very nice case and telling us about what are the basic steps that are involved. So quickly, I'll just give 2 or 3 scenarios of stage 4B. Retinal detachment. So this was an outborn 30-weeker, 1780 grams, history of oxygen supplementation, diagnosed as aggressive ROP outside, and laser was done. Now here, when we see the clinical photograph, we see there is a posterior location of the 4B. There is a fold which is along the arcades, and if we look carefully, that there is also a connection, interarcadal connection, and we also see an avulsed vessel here. And the macula somewhere is dragged superiorly. So this is a 4B with a posterior location. These cases are relatively easier to tackle, and the surgery may be simpler rather than a more peripheral one, which I'll just discuss. So this is just the surgical video for this case. I try to do most with the 27 gauge transconjunctival vitrectomy in most of my cases, and the surgical principles remain the same. Like you can see here that there is the vitreous traction going from the ridge to the periphery, from the ridge coming up anterior to the lens, it is between the arcades, that is the ridge to the ridge, and also over the disc. Now, in these situations, we may use a little amount of transfer to identify the posterior vitreous tracts, but if we just try to do these planes, I think most of the time we are able to get away with it. And there is sometimes a FPL which is located over the disc, and sometimes it becomes fibrotic. If we can peel it off a little bit, it gives a better result. Otherwise, we may need to peel a little disc drag. I tend to leave all my cases under air, and in 27 gauge, I usually don't apply sutures. So this is the outcome of this case post-operatively. The next case is of a relatively more peripheral traction. In these cases can be managed with either a scleral buckle or doing a lens sparing vitrectomy. The sclerotomy ports may have to be modified with the shifting of the infusion cannula, either only the infusion cannula, either nasally, or which has been described by Professor Dogra and Simar, that we shift all the 3 ports nasally with the infusion cannula placed in the center and the cutter and endolite on either side. The intraoperative OCT which we have just helped me to delineate the vitreous membrane that was there between the folds. I do use triamcinolone because it helps to identify this small amount of vitreous separation which may be present in such cases. We don't need to induce the posterior vitreous detection PVD completely, but at least in the posterior pole, if we can do it, it does help to give a better result in terms of the anatomical success. So I'm using a forceps and just going up to the ridge, because beyond that it's very difficult to peel off these membranes. So just going as comfortably as up to the ridge and trying not to induce any retinal break here. And again, air exchange, and this is the outcome. The macula is attached and the fold has opened up. One more case. This is another case of a 4B detachment. Just speed it up a bit. This is somewhat similar to what Dr. Tapas has said. This is vascularly active disease. In this situation, we need to give a preoperative anti-VEGF at least 2 to 3 days before, and give it only when the child is fit for surgery. You can't just give it and then wait for clearance. The clearance has to be done before. Possible to do as much of laser beforehand, and sometimes if it is not possible, we may need to augment it intraoperatively. So do that intraoperatively to reduce the vascularity. Here we just need to clear up again vitreous to anterior, vitreous to periphery, and the inner arcade. Yes, this is the outcome after surgery. And I think in the interest of time, I'll just skip this. Thank you for patient hearing.
Thank you so much, ma'am, for some very interesting cases and showing the complete spectrum that we see of